I'm Tim. I'm an X-ray doc. I'm Tim Gormley. I'm an X-ray doc. I'm a radiologist. And about 50% of my practice is mammography, breast interventions, breast MRI. And what I do is I convert what could be the #1 cancer killer of women into something that's further on down the line. And I have some statistics and numbers, and I have some movies too. But in summary, what I do is I try to take bad things that hurt our fellow human beings, and I try to make those bad things a little bit less bad, manageable. It's a scary thing. You're shaking your head, you know. When you tell a woman that there's an indeterminate finding on the mammogram, her life flashes before her eyes. It gets you in the gut in a way that almost nothing else does. It gets you in very immediate touch with what could be your own mortality. Anyway, that's what I do. My name is Tim Gormley. I'm an X-ray doc. I'm not a really great speaker, so forgive me in advance. We'll do this more friendly style than formal style, if that's okay. So I want to start with thanks, because every one of us is a product of our environment, and I have thanks that I need to give. I have debts that I owe. To the Catholic Foundation, to the Tri-Cities Cancer Center, Catholic, my home institution, the place that gives me a chance to do this. Thank you. I wish there was a Catholic thing here that I could thank more directly. And my teachers, colleagues, patients, and my parents. Okay, that was my standard thing, so I've already started off. And this is the truth as best as I know it, but if you know something different, sing out and we can talk. Conclusions, opinions, all the errors, all of the mistakes, those are mine. And and my disclaimer is, I do this for a living, so to that degree I could be biased. However, the evidence is impartial. The evidence doesn't respect bias, and that's what we try to base our clinical practice on. So that's the general introduction. And what breast cancer is, you know it. Some of you have lived it. There are about 200,000 cases diagnosed every year, about 40,000 deaths every year. They've recently redone the numbers, and breast cancer is actually increasing in frequency. When I was in training, they would say 1 out of every 11 women would have breast cancer. And they say, well, that's an exaggeration because you're counting precancers in situ as disease. So maybe it's even fewer than that. Well, that's not true. Breast cancer, even if you adjust for age, even if you adjust for demographics, breast cancer is increasing in frequency. Increasing in frequency. And anybody who tells you that they know why, that's a misrepresentation of the truth. Maybe it has to do with environmental toxins. It isn't due to the aging population, because we adjust for that when we look at the data. And now, over the course of a woman's life, 1 in 8 of them can expect to have a diagnosis of cancer or in situ breast cancer over the course of their life. And just a back of the envelope calculation, looks like there's about 30 to 40 women in the audience. That means several of us here will have that diagnosis or have had that diagnosis over the course of their life. And one of the things in medicine is we have what's called HIPAA, but really that's a government regulatory agency and set of guidelines that really just reflect what's common sense and right. We respect your medical confidentiality. We respect your privacy. But if you look across this room, statistically, there's probably at least 2 and maybe as many as 5 of you have had malignancies of your breast or will have over the course of your life. So here in the Tri-Cities, one of the things that we do in my department is we always want to make sure that we're doing right. So what we do is we look at the demographics of our population. How many women are in their cancer years in the Tri-Cities? And a back of the envelope calculation is about 130,000. The lifetime risk is about 12%. And that translates into 21 deaths each year in our community. If you take, the 4 cities in the Tri-Cities, that's, there's 21 women a year. The national murder rate is 5 out of every 100,000. And here, we're at 21 per 100,000, give or take. So more women in the Tri-Cities not just are diagnosed with breast cancer, but will die from breast cancer in the Tri-Cities than all those headlines you might read about when somebody does something terrible to another fellow human being. I mean, this, if you look at the numbers, is about 4 times more significant. And it doesn't make the newspapers. It affects families, it affects individuals, it affects people. But it doesn't get the headlines to a certain degree. To a certain degree, it's accepted, but we don't accept it. And every individual person every statistic is an individual person. These are some people who had breast cancer or died from breast cancer. And if you're an old movie buff like me, you might recognize some people. All of our fellow human beings. And scientists. And this was a person who I went to high school with. She died at age, I think, 41 or 42, 41. And she was nice, and she was interesting, energetic. She's like one of those really nice, interesting, vivacious human beings, and she was a mom, and she's been dead now for about 10 years. So, every number, when we do epidemiology, when we look at our statistics, it's important that we do our statistics because that tells us that we're matching the incidence of disease in the population and not missing things. But then you have to take a step back from the statistics and you have to remember that each one is a person. And there's lots of people, and they all need to be looked out for. This is a different story. This is a story of a 65-year-old grandmother. She was the daughter of a steel worker. She was the first in her family to attend college. When she attended college, her dad didn't know really what the heck she was doing because he didn't go. And so, what he did was he built her a bookshelf as a way of physically telling her that, hey, look, I support what you're doing. I don't understand it, but, Anyway, she taught high school for 36 years. She had a second career as teaching recovered students. When she retired from, teaching high school, she actually went back in a program where they had volunteer retired teachers help people who dropped out of high school get their GEDs. So, one of the economic kisses of death in the economy is to not get your high school diploma, especially these days. That was what she did for her second career, helping people who dropped out of high school get their GEDs. And she also raised 2 difficult sons. And she had an 8mm spot on her mammogram. You can see that right here. And they watched it for 6 months, and you can see how it grew. So her story was she met a radiologist, and he seems very nice, but he always wants more pictures. She met a surgeon. She seems nice, but so serious and young. And she met other doctors, oncologists. One of the things that's great about being in the Tri-Cities is that we have a lot of medical expertise here. We have radiation oncologists. We have hematologist oncologists. We have surgeons who intervene for breast malignancies every day, and they're good at it. And we work together hand in glove, because medicine is a team sport. There's no heroes in medicine. It's a team sport. And one of the people, the patient is the first person on the team that we're all centered around, we hope. But she was afraid. Whenever you get a diagnosis like that, you wonder, am I going to live? She didn't know. Well, she did live. She still likes to collect diamonds. She likes to shop on Craigslist. And she'll see her granddaughter married, and she's my mom. So, and that's the other folks in my crew. So that's my mom. She lived. So that's why I do this for a living. It's not a, everybody has their, I apologize for speaking badly. I'm not that good at this. But this is why we fight. This is why we get up in the morning, because everybody that you meet knows somebody else, and we're connected to each other. We love and we're loved by the people around us. That's why we fight, to make this bad thing less, And breast cancer is increasing in incidence. If you look at this is back to numbers, less people. Female breast cancer is, by far and away, it's the most common skin malignancy that women are going to be at risk for or are going to suffer. This is not even close to lung cancer, not even close to colon rectal. I mean, those are important malignancies too. If you smoke, please stop. And the reason why is because we want to look out for the whole person, not just parts of her. But in terms of raw numbers, breast cancer is the most frequent malignancy. The incidence is rising for all ages. If you take everybody's age-matched demographic group, 15 to 39, very low but baseline terrible incidence of disease, the incidence of disease is increasing for all demographic groups, for all age groups. But the mortality is dropping even faster than the incidence is raising. This is a great frickin' thing. What this means is that we're pushing it back. We haven't beat it, but we're pushing it back. Now, if you've ever seen the course How to Lie with Statistics, you watch me. I would not do it honestly. I pulled this from data because this is national data. But you see how they have the y-axis at 30 and 20 here? They make it look, and what they do is they make that dramatic different. The 30 and the 20 is a little sleight of hand, and that's why I wanted to, in full disclosure, bring it to your attention. The story isn't as good as this, but it's still good. So what that means is the incidence of disease is increasing, and the survival is increasing even faster. That's great. That's tremendous. And the reason why is almost certainly because of our ability to detect this early. I suspect that I'm not telling you anything that you don't know. You're an involved community. You know this, that's why you're here. And so if you have any questions or if this is too basic, accept my apologies. But the secret is early detection, and it's no secret. If you diagnose it at stage 0 or 1, the staging is a combination of how big the lesion is, how the lymph nodes are affected, and where disease is elsewhere. All these three variables come together to form a staging diagnosis once you have a diagnosis of disease established. What this means is if you can detect disease early, you're going to make it a memory. If you detect disease late, it's still a memory, but it's also a fatality. So here is another way of looking at the same chart. So, if you have disease at stage 1, if it's less than 2 centimeters, my goodness, you're going to, your 5-year survival is going to be 85%. And when you consider that the demographic are folks that are most commonly in their late 50s, early 60s, early 70s, I mean, this is survival all years from all reasons from all causes. There are some, heart disease is still the #1 killer in women. If you're not taking care of your cardiovascular system, if you're not doing some type of physical exercise every day, if you're not watching your blood pressure and your cholesterol, please do those things too. Because you've heard this before, we want to save the whole person, not just parts of her. But so those numbers are going to be suppressed also by the fact that there's other mortality in the population. But the summary is the earlier disease is detected, the greater the survival. Unequivocally by far. I'll move so you can see too, sorry. Or is that good, sir?
That's fine.
Okay, cool. Yes, sir.
Excuse me, what does the DCIS stand for?
Oh, thank you, sir. Always challenge, always question. That says ductal carcinoma in situ. Think of cancer as a bad horse. And when the horse gets out of the barn, it can grow, it can metastasize, it can breed. All right? And that puts my patient at risk for life and welfare. Think of DCIS as a bad horse that hasn't left the barn yet. It's still local to the ducts. It has not invaded beyond the adventitial layers of the blood vessels. It has not exceeded the boundaries of the ducts of the connective tissue. It is a cancer, but it is an in situ cancer that hasn't spread. It's not invasive yet. Does that make sense? DCIS, ductal carcinoma in situ. Most of these are adenocarcinomas, and if you want, I can take it up at least one notch, in that these are carcinomas like lung cancer and like colon cancer are cancers of epithelial origin, and they tend to occur at a certain spot in the ductal system of a woman. They tend to occur at cellular junctions, where the squamous cells of the tube meet the columnar cells of the glands. right where you have an epithelial transition, right where you have that transition, you have a weak spot, at least genetically. And that is where cancers generally, not always, originate from. And if you think about it, lung is the same way. You know, lung cancers occur at that same mucosal junction, and rectal neoplasms from the colon, most of them are at the dentate line in the distal colon, where the epithelium changes. Change is bad sometimes. So anyway, that answers that question. And the other thing that I want to note is that if we find the cancer at 2 centimeters, not always, but in most cases, that's a save, 2 centimeters or less. At my department, you know, when I was doing the chairman thing, what I did was I looked at how good are we? What is the average size of the cancers that we find in the Department of Radiology? You know, when we find a cancer, we figure out how big was it? Could we have done better? Nationally, last time I looked at the data, nationally, the average cancer is found at about 8 millimeters. We find them at 6. And that's not questionable findings where you bring you back terrified for a diagnostic. That's when we actually find the cancer. And if we find a cancer at 6 millimeters, there's no 100% promises. There's anxiety, there's interventions, there's expenses, but there's a save. So yes, sir?
The cancer, is it something that starts within you, or is it introduced to your body somehow?
That's a brilliant question, thank you. What cancer is you have cells in your body, and the postulation is that you have some type of environmental or genetic insult in some way, and the gene regulation changes. When we started off as single cells, you know, way back long ago, when we started single cell organisms, you know, we just have one fertilized egg, right? And that fertilized egg grows and divides, grows and divides, grows and divides. And then, eventually, the cells get specialized. Some cells become muscle, some cells become retina of your eye, some cells become lining of your breasts, ducts, glands, fat. The cells specialize. Cancer is where the genetics are altered in some way so that parts of those processes are reversed in an uncontrolled way. So these cells just up and do their own, I can't say damn on that thing. Okay, they just, okay, oh, he's loud. Okay, these cells do their own thing in an uncontrolled way, independent of the health of the rest of you. And then they spread and they grow, they spread and they grow, and that's the pathogenesis. Does that make sense? Cool. And I would like to thank you for interrupting. Please do. It makes me think that I'm doing my job. Okay, so the summary of this slide is you find the disease early, and you convert what would be a fatal disease into an inconvenient day. So finding disease early is critical to saving our fellow human beings. But it starts with you. Not all breast cancers are found mammographically. A lot of breast cancers are found on your own self-examinations. Your self-examinations are best done at a regular time, on a monthly basis, at the end of a cycle or at a regular point in your day or life where you're able to take maybe at least 10 minutes to, in a careful, methodical way, examine your breasts in terms of how they look, what their skin changes are, what the contour is like, and what the underlying new changes are. Many women have dense, complex breasts, and the examination, and a cold examination can be difficult. What you're looking for is you're looking for changes. You're looking for something that is unique, new, and different. The best time to know you're you is as soon as possible before you have disease, and then you can look for changes and hopefully with direct imaging to identify if there's disease or not.
How to recognize breast cancer symptoms. Over the course of a woman's lifetime, she may experience breast changes. While many end up being nothing to worry about, it's important to have any changes that you notice checked by a doctor, just to be on the safe side. Here are the potential breast cancer symptoms to watch out for. You will need a monthly self-exam, attention to breast changes, a medical exam, and annual mammogram starting at age 40. This video does not replace actual medical advice. Always consult your doctor with any questions or concerns. Step 1. Start performing a monthly self-exam as soon as your breasts are fully developed. Checking yourself regularly is important. You need to know what your breasts feel like normally so you can recognize any changes. Examine yourself several days after your period ends, when your breasts are least likely to be swollen and tender. If you're no longer having periods, choose a day that's easy to remember, such as the first or last day of the month. Keep in mind that it's not uncommon for breasts to feel lumpy due to benign fibrocystic breast disease, cysts, scar tissue, infections, and other causes.
Those are
that
the
have nothing
network
to do with
lattices that I was
cancer.
talking about, the
For
fibroskeleton.
instructions on how to do a breast self-exam properly, go to breastcancer.org. Step 2. Know what you're feeling for. A lump that feels different from your breast's normal lumpiness, like discovering a pebble in your
Versus
oatmeal.
this.
Though many lumps are benign, anything that feels new or odd should be checked by your doctor, even if you've recently had a clean mammogram. Check for lumps in your armpits, too. Cancerous lumps are more likely to be hard, painless, and unmovable. Step 3. Look for visible changes like dimpled, puckered, thickened, reddened, or scaly breast skin, or a flattening or indentation on the breast. All are potential breast cancer symptoms that should be evaluated. Step 4. Recognize the nipple changes that can indicate breast cancer. Pain, redness, scaliness, itching, skin thickening, the nipple turning inward, or discharge other than breast milk. Step 5. See your doctor about swelling in all or part of your breast, or breast pain. Though swelling and soreness are usually no cause for concern, these symptoms can be signs of a rare but aggressive form of disease known as inflammatory breast cancer. Step 6. Have your doctor perform a breast examination at your yearly checkup and begin annual mammograms at age 40. If you have a family history of the disease, tell your doctor. They may suggest that you start having mammograms at an earlier age. Knowing the signs of breast cancer and being proactive about knowing how to recognize them early is the best way to protect yourself. Did you know? In a breastcancer.org survey of more than 2,200 women, 37% said they first detected their breast cancer with a self-exam. For more information on breast cancer,
That's good.
visit breastcancer.org.
Okay. Now, I'd like to take a moment and answer any questions anybody has about that, because that's important. You know, medicine is a team sport, and if you have any questions about self-examinations or things like that, you can ask me now or later as you see fit.
Question.
Yes, ma'am.
Do you know on average how most women, what size that they would feel?
That's a good question. I have an approximation, but I don't have a paper in my mind. But in general, it has to do with proximity to the skin. The closer it is to the skin, the more sensitive your self-examination is going to be. It also has to do with your body, too. The larger the breasts, the more breast tissue there is. Breast cancers occur at a non-uniform rate within the breast. They tend to occur at glandular junctions, both anterior and posterior. And so if a woman has larger sized breasts, her examination is going to be less sensitive. But to answer your question, about 1 centimeter. Mammography is better, but your self-examination is really important too. Yes, ma'am.
I have read somewhere that at a certain age, as you get older, you can skip mammograms.
Oh yeah, I love that question. That's one of my modules. And that is, I know people, and you know people, and not everybody who's 70 is the same 70. Not everybody who's 80 is the same 80. And look, age-specific rates of breast cancer. And look, so here is the number of breast cancers diagnosed on an annual basis for every 100,000 women years. So if you look, if you're 85, you're still in a cohort that's going to have 300 breast cancers diagnosed a year. So it is absolutely true that after age 80 or so, your risk of breast cancer decreases. It decreases some, maybe 20%. So here is what I recommend to patients. My job is to serve you as you see fit. Part of that is to tell you what I recommend and why. And not every patient who's 80 is the same 80. If you, at 80 years old, anticipate yourself living life and doing things at age 90, then you absolutely should get your annual mammogram. If you're not sure, then you should absolutely get your annual mammogram. If you are 70 And if you're in the ICU and you have multi-system organ failure and you don't anticipate being alive in a year, we're not going to bring the mammogram machine into the ICU. So what I do is I recommend the 5-year rule. First off, I'm here to serve as you see fit, not as I see fit. So I have to be respectful, listen to, and be deferential to your inclinations. But if you see yourself as living a healthy, enjoyable life 5 years from now, then you should get your mammogram. And that's true if you're 90. And the reason why is because the numbers are still pretty high. If you don't anticipate yourself living your life in a way that you see fit, in a way that gives you joy and happiness in 5 years, well, then there's maybe other things you can do with your time. But if you're 90 and if you plan on kicking butt at age 100, please get your mammogram. Does that make sense? Okay. So this is the age-associated incidence of disease, and this is not the cohorts that we're talking about where the disease incidence increases over time. I think this is the 2016 expected incidence rate for cancer at each year in 2016. So we talked about the importance of breast examinations. That young 42-year-old woman who I diagnosed earlier today, like about an hour ago, I'm going to remember this for a long time, it's going to be a good thing. Most breast cancer still isn't found with your own self-examination. Most breast cancer is clinically occult and not found by your doctor's examination either. Most breast cancer is detected on imaging. Mammography is best when the cancer risk is highest or when the breasts are less dense. So mammography isn't, yes ma'am. Yes ma'am. That's a really good question. So your question is the 3D tomosynthesis a typical part of your screening mammography? And at this institution, the answer is yes, but we have an opt-out option too. Our philosophy in our department is the philosophy of the most good. We are here to recommend. We're here to inform as best we can. We're here to listen. And then after we make our recommendations, we give the patient the most good that they're willing to accept. So if you have a palpable abnormality and the right thing to do is to do a diagnostic mammogram with 3D imaging and an ultrasound, and if you say, hey, look, the only good I'm going to accept is the ultrasound, my answer is yes, ma'am, after I talk to you about it and see if I can address your concerns. We'll give you the most good you're willing to accept. The 3D mammogram is a standard part of the screening imaging that a woman has at this institution, but you can opt out of it. What are the advantages? Well, we increase our detection rate, especially in women with dense tissue, and we decrease our callback rate, and I'll have some numbers to show you in a minute. But there is a little bit more radiation involved, there's another imaging involved, and in some cases there can be more expense involved. Yes, ma'am.
I got a letter last year that my mammogram appears normal, but that does not mean you don't have breast disease. So what does that exactly mean?
Okay. I don't have the letter in front of me, but what I think that it means is that imaging is just part of the picture. What that means is if we don't see any evidence of malignancy on your mammogram, that should be clearly stated. There's a couple things that we owe each and every one of our patients. Some of them are dictated by the FDA, some are dictated by what's right. And in some cases, if a woman has a palpable abnormality, and if we don't see any imaging evidence of disease, we say that we see no imaging evidence of disease, but the palpable abnormality should still be evaluated on its own grounds. Because some malignancies, not all malignancies read the book, some are very infiltrative and hide by growing in the interstitium of a breast without distorting the architecture. So if you have a palpable abnormality, for example, and if you have normal imaging, well, that's good, but it's not completely predictive against the possibility of disease. And that palpable abnormality should still be evaluated based upon you and your doctor's examinations. And if there's a true palpable abnormality that is there, They can biopsy by palpation, or they can do an MRI. That might have been your case, but I don't know.
But they don't want to do it before a year is up.
I'm sorry, ma'am?
They don't want to do it within a year.
Do what within a year?
Anything, I mean, because of insurance and blah,
Okay.
blah, blah.
I don't, they keep me away, they keep me far away from the money because I'm not too careful with it.
Fight for yourself.
I'm sorry, ma'am?
You have to fight for yourself.
Yeah. Well, the thing is, if there's a palpable abnormality, then it goes back to the doctor for evaluation. And I don't know if that's the case or not.
But you always have to go to the doctor first, right? And then get further examination.
That's actually not true.
Oh,
Can I tell you why? Because we did this. Because, okay, one of the most perplexing things on planet Earth is when you tell a woman, hey, look, I think that there might be disease here, and go follow up with your doctor, and we'll get an order from the doctor, and your call is very important to us. But if you're having an emergency, call 911. Listen very carefully, because our phone options have changed. I mean, don't you want to kill somebody after that? Okay, I hate it too. So what we did was we have what we call a reflex system. If your doctor has plugged you in as a reflex patient, if we see an abnormality on your screening mammogram, then automatically we can schedule you for a diagnostic mammogram, nothing in between. And then if we see an abnormality on your diagnostic mammogram or an ultrasound, boom, we can schedule for a biopsy. No nonsense in between. We have a biopsy nurse in the hospital on site most of the time, and we can move your care forward without these annoying delays. So it's a reflex system, so it's not always true. In fact, in the majority of cases, it isn't true that you have to go through your doctor first. Yes, ma'am.
Is the Cadillac Radiology Center over on, across from the?
Yeah, it's the 945 building.
No, the one over on Deschutes, across from the Cancer Center, is that Cadillac?
No, that's the Tri-Cities Cancer Center. They do good work. I've seen their stuff.
It's not Cadillac.
No, ma'am, it isn't. It may still look good. No, ma'am, it isn't. But, the number one thing is looking out for you. We are not territorial. You should get and seek care. They do good work there, and you should get and seek care in the place where you're comfortable with. Medicine is a matching thing. What you deserve, what you ought to have is you ought to have medical care in a situation and in an environment that's comfortable for you. So if that's more convenient, if that's there, yeah, use them. They're good too. You don't have to send that part to the admin guys. Don't get me in trouble.
Is the 3D a different test than the
I have some pictures.
compression?
Okay, that's perfect, right, and beautiful to ask. 3D mammogram has the same technology, but it's a little different. Do you mind if I talk about that when I have the slides? Because I have a really cool movie. Okay, so mammogram has strengths and it has weaknesses. One is we will not see all cancers on the mammogram. I wish that wasn't true. But knowing that we're not perfect allows us to be safe because we have backups to our backups. There is no path of no risk. We try to navigate a path of least risk. So knowing that the sensitivity of mammography is about 84%, the specificity, sensitivity is your ability to see disease if it's there. Specificity is your ability to not see disease if it's not there. In other words, those scary letters that we send that end up being nothing most of the time? That's the specificity thing. Positive predictive, I'll spare you the statistics. Okay. So the recommendations are annual screening mammography at age 40. And one of the reasons why we feel strongly about that is because we'll save lives if we do it. Yes, we'll have false positives. Yes, we'll cause interventions and expenses that we wish we didn't. But we only know that we don't need to do that in retrospect. And, if you save a life, that's pretty persuasive. So the balancing harms, we always want to be, a doctor that's worth a darn always has to think, what are the problems that I can do? What's the harms I can commit? Where can I commit errors? So with mammography, will cause fear, will cause further imaging, diagnostic tests, discomfort, pain with intervention. I've been told that a mammogram is something similar to the weight of a car battery on your chest. That can't be fun. But it's an unbalanced harm because if we find a cancer, and we do, I found one today, that translates into a saved life. that translates into a disease that's found at an earlier stage and translates into an improved survival curve like we saw before. That's gold. This is what drives action, not cost effectiveness, not the fear. I wish I could avoid the fear. I wish I could improve the modality. I wish I could improve myself. But knowing where our priorities are is the critical issue, and our priority here is to save women's lives. And those are references. If anybody wants a copy of the slide deck, can that be made available to them?
Yeah.
Okay, so I haven't gotten pre-approval, so I hope I'm not getting in trouble. But if you want, you could write down your email. You'll collect the emails, and I will send you a copy of my slide deck if you want this. I'm not territorial. You can present it to your colleagues and share it amongst your friends. It's like 40 megabytes, though, or bigger. Okay, so here's traditional mammography, and I'm going to slide into 3D mammograms. I think everybody here knows. Yes, ma'am.
Do you check a man's breast the same way you check ours?
Do you mean for mammogram, or do you mean for physical exam?
No, I mean physical and mammogram.
Males typically.
They couldn't do a mammogram, obviously.
No, they do.
Yes, they do.
They call it a mammogram. You can edit that out. This is good. I'm going to be so terrible. Yeah, but okay. To answer your question, we do imaging of the male chest, and the reason why is for the same reasons we do imaging of the female chest. The differences are, though, that the imaging of the male chest is typically driven by a palpable abnormality, a complaint, a discharge, something abnormal with the physical examination or the clinical presentation. Women, we screen. If you are a healthy, asymptomatic 50-year-old woman, we'll give you a screening mammogram. We'll beg for you to have a screening mammogram. Males, they don't get screened that way. And the reason why is because of that sensitivity specificity thing. Do you mind if I slide into statistics for a little bit? Okay, specificity is your ability to not see disease if it's not there. Double negative. So if I was like super powerful, or if I knew everything, or if I was right all the time, and if I knew that 100 women walking into my door did not have disease, every one that I called a positive with my test would be a false positive because I know that they don't have disease. So that would be a defect. For males, the frequency of chest wall malignancies is low. And so my ability to be right critically depends upon the frequency of disease in the population. If I have 1,000 people walk through my door and only one person who has disease, and my test gives me 10 positives, most of those are going to be false positives. For men, it's even worse than 1 in 1,000. So my ability to be useful depends upon disease, the frequency of disease in the population. Does that make sense? Okay. And that's why, so males, they get a physical examination by their doctors. We don't do that. And we don't do routine imaging of them unless they have a problem or complaint or a mass. So traditional mammograms show pleomorphic microcalcifications. What that is that's abnormal cells dying, growing, reproducing, growing, hypermetabolic, collecting calcification, and depositing irregular calcifications in the parenchyma and in the ducts. So this is an example of a malignancy, an in situ cancer. The bad horses start off in the barn, they get out, then they multiply. I don't know if this is out of the barn yet. Here is a bona fide malignancy. Remember how we talked about how the breast has internal architecture, has like a fibrous connective tissue skeleton, no bone, but a fibrous connective tissue skeleton? Here you can see the distortion of that fibrous skeleton. You can see the breast malignancy drawing in that skeleton, indenting the skin, withdrawing the nipples, thickening the skin, and here's the spiculated mass. The reason why cancer is called cancer is because ancient Greek doctors, when they would take cancers out of cadavers, would notice that the tissue was grabbing onto the other tissue like a crab. That's one of the reasons why I think, no, you can check me, but I think that that's why they call it that. It's grabbing onto the other tissue and involuting it, drawing it in. So you can see all the signs of an infiltrating malignancy right here. Skin thickening, distortion of the architecture, parenchymal distortion, mass, retraction of the nipple. So that's what traditional mammograms show. Dense breasts decrease our ability to see disease. One of the things that we owe you, both on the basis of what's right and on what's regulated, is a report on how dense your breasts are. Dense breasts are not disease. In that video that we showed, they call fibrocystic disease. For me, disease is something that hurts my patient. And consequently, I'm hesitant to call fibrocystic disease disease, because if it's not going to hurt my patient, I don't care. But dense tissue hides disease. So know how dense your breasts are. That should be in the mammogram report. If you're on K-chart, you'll see it. You know, less than 25% density, that's predominantly fatty. Level 2, 50% density. Here's the white glandular tissue, which is increasing. And here, grade 3, scattered heterogeneously dense, and very dense breasts. Very dense breasts are still served by mammography, just not as well. And here's why. Here's a breast that isn't particularly dense, and you can see a malignancy right here. It stands out like a light bulb. Here's a woman with dense glandular tissue. This is a biopsy-proven malignancy. It correlates with a palpable abnormality. This is very hard to see on a mammogram. If this was on a screening mammogram, most people would miss it. This woman saved her own life when she detected a palpable abnormality, and that directed us to it. Otherwise, the case would be lost. This woman saved her own life. Good for her. So that's why dense tissue is problematic for screening mammography. It's not useless. It just means that the value of the test is less. Our ability to see disease is impaired. Our sensitivity, our ability to see disease is less. Our specificity, our ability to tell you it's normal when it's truly normal, that's impaired also. 3D imaging, what we talked about before. What that is we take, like, you know how the CT scan has a donut and it goes around? 3D mammography is just like that, pretty much, except there's no CT scan, but we still use tomosynthesis in 3 dimensions by taking multiple views of the breast along a whole arc. And then we reconstruct a 3D image of the breast. It's really great. I hope my movie works. Okay. So the movie will come up in a moment. I was offbeat there for a second, sorry. So what is the benefit of tomosynthesis? Why do we recommend it to our patients as part of our regular screening process? Well, it increases detection by up to 30%. Also, it's good for dense tissue. It lets us look through the dense tissue in a way that the conventional mammogram doesn't do as well. Is it perfect? It surely isn't. But it does reduce our callback rate by about 15%. If you've ever gotten one of those callback letters, you know how anxiety-provoking it is. We want to call patients, ideally, we want to err on the side of caution. Would like to call patients back if needed, but not unnecessarily. And so the 3D tomosynthesis reduces our callback rate by 15%. And that's anxiety and expense that those women don't need. And when I looked at our numbers here, our callback rate used to be 14%, now it's about 10%. So I can prove with numbers, when we look at the imaging that we do at this institution, that our callback rate has decreased because of tomosynthesis. And our detection rate has increased also, our detection rate of true disease. Yes, it's additional imaging. Yes, it's a little bit extra radiation, maybe 1.5 times. But our patients win both ways. That's why we fight. And here's an example of a regular mammogram versus a tomosynthesis lesion. Okay, the tomosynthesis isn't perfect. We talked about some of that, and I'm talking too much, so I'll fly through some of this. Tomosynthesis works. Okay. American College of Radiology thinks it works too. Can we play that video? No, there's no audio. So here we have the pictures along an arc, and here's the tomosynthesis. Here's all the pictures, and then the pictures come together to make one 3D picture that we can then construct and deconstruct. Like that. It is actually that cool. And you can see the malignancy right here. You can see how it's withdrawing the local connective tissue. So that's what, thank you, sir, I'm grateful to you. I have a couple more, I hope that's okay. So anyway, so that's what a 3D tomosynthesis is. Did that answer your question? Okay. So US Preventive, do you mind if I do Preventive Task Force stuff first? So what they said was, okay, mammography between the age of 40 and 50, they said approximately this. Mammography between the age of 40 and 50 detects some disease, but most people don't have disease. It generates a lot of false positives, a lot of expense, a lot of worry, and therefore it's not indicated because there's not enough bang for the buck. My thought on that, do you mind if I... My 2 cents is I'm not in charge of defending the public purse. I'm in charge of defending a human life. So screw 'em. So that's what I think. Okay, yes ma'am.
So are you recommending that we have that kind of test instead of the regular mammography?
You will have this unless you opt out of it.
What?
This is what we do for everybody unless you say no. Unless you say no, unless you tell the technologist, I don't want a 3D mammogram, you'll get a 3D mammogram automatically.
So the
Instead
one
of-
that they give at the building 945?
Yeah, 945 billing, you'll get both.
That's
Yes, ma'am.
fine.
Yep. Our default is the best. Yes, ma'am?
Yeah, I only got one.
This year.
No, you mean one mammogram or 3D mammogram? You may have gotten a 3D mammogram and not known it. Because because if the machine goes, it's the same. You're quite sure?
Oh, I'm quite sure.
Okay, can I take your name and I'll give you my name and number at the end of this? And what I'd like to do is I'd like to investigate this. If there's an error, I want to fix it. Yes, ma'am?
Is that the same machine though?
Yes, it is the same machine, absolutely. It's the same machine. Well, if you do this for a living, you'll know, because the machine makes an arc around you. But if,
So you know it?
I'm sorry?
Does it move so you know? Because they bring that big thing.
Yeah, they put you in compression, and then the X-ray tower or the X-ray tube moves in an arc. It's the same machine. So we have to turn off a setting in order for you to not get it. If you had, the number of 3D mammograms that we do is about 98% now. So yes, ma'am.
Since when did you start?
We started doing this about in 2016. And for the first couple of years, we had some people say, "Hey, look, I don't want it because of radiation," and then we always talk to them about it, and then defer to them once they make their decision, and then we had a couple people back out because of expenses, because of being priced out of the care. But if you had a mammogram, I don't know about your case in particular, and I can't pretend to know when I don't. But I've been reading mammograms all week, and I haven't seen one yet that is only a 2D mammogram. And so, that is at least the truth for most people right now. So here is a malignancy on a 2D mammogram, and here's how it can be brought into great relief on the 3D mammogram. You can see, because what it does is it images the tumor independent of the tissue around it by taking a slice right through the lesion. It's an imaging slice. So that's the tumor on the 3D mammogram, and that's where it would be on the regular mammogram. So we also have computer-assisted detection. Computer-assisted detection makes us a little bit better. It's not a huge difference. But quality is built upon small, solid bricks. Anything that we can do to increase our sensitivity and increase our specificity, anything that makes us better, we will embrace. So we have the computer also tries to detect malignancies, and this is an example of computer-assisted detection. And all of these modalities together, your physical examination, the 2D mammogram, the 3D mammogram, the computer-assisted detection, that all works in concert that all works together to try to detect disease. So in most cases, we don't detect disease. There are no clinical symptoms, and then an annual screening mammogram follows. Sometimes we do detect, about maybe 10% of the time, we detect something. Doesn't mean that there's disease, it just means that we have a question, and then there's a letter that's generated. And most of the real disease we detect, some women with dense breasts, some women are not all women, but in most cases we find it when it's pretty small. And I've looked at the actual data that we do here to make sure that we're in line, and yeah, we're actually in line or better. Here's our sensitivity or specificity. Here's comparing 3D to 2D. This is when we actually had enough data back in 2016. Right now, the number of 2D mammograms that we do on an annual basis, I'm thinking, is probably less than probably less than 50, and the number of 3D mammograms that we do is well over 1,000, probably a month. Okay, so there's the pathway of imaging care, because I want to make sure I don't run out of time. So basically what we do is we do the screening mammography. The screening mammography is abnormal. Then we investigate the question further with ultrasound, diagnostic mammogram, specialty views. Sometimes MRI, more often than not. We do a 6-month follow-up examination or a biopsy. These biopsies are anxiety-provoking, but they're low risk. The breast is essentially a modified skin gland. I'm not going next to the aorta and the mediastinum. This is not a dangerous procedure. It's anxiety-provoking. It's serious. It has to be done right. But in terms of the risk to a woman's well-being and welfare, the number one risk is not having a procedure that she needs. So we do the biopsy, and if we find disease, we send out the dogs of war and we attack. So if you have disease, some of you have had disease, some of you will have disease, I hope not, but statistically it's true. I recommend that patients keep a little journal or a little log. Write down, who do I talk to? How do I get a hold of them? What did they say? What questions? I always hate to use these hippie words, but I want people to feel empowered. And by what I mean by that is I want you to have some control over the information. Write down what questions that you had. Write down what concerns you have, who you talk to, and that will give you some type of control over your own narrative. I can't control whether you have disease or not, and you can't control that either. I wish differently. But what you can do is get control over your information, keep a cancer log, keep a cancer journal. And if you have disease, who do I talk to? What's the next step in my plan? What concerns do I have? Who do I talk to? We're here for you. You're not here for us. So write down what your concerns are, what your values are. Another patient I imaged her, and she was about 95. And she had a palpable abnormality. Her doctor brought her into mammography. She was yesterday. And she had maybe a 1.5 centimeter mass behind her nipple with nipple retraction. And I talked to her and her daughter, and firstly I had to respect her because she's in charge of her life, but she fully said, hey, look, you can talk to my daughter too, we're a team. And she said, hey, look, I'm not going to be around in 5 years. So I said, well, this is what we recommend and what we can offer. Not every cancer diagnosis has to be met with surgery. Not every cancer diagnosis has to be met with maximum chemotherapy. There are perhaps some things that we can do that will decrease the bite of your disease, decrease the impact of your disease, but still not impact the rest of your life. We can work together based upon what you value to accomplish your objectives. So that was a different patient. So you always want to write these things down. Advanced modalities, diagnostic mammograms, specialty images, ultrasound, MRI. They have thermomammograms in the community. There's no evidence that they work any better than no imaging. I'm not allergic to them, but I think that they don't serve my patients, so I don't see a value in them. Here's what malignancies look on ultrasound. Ultrasound is really good as a targeted modality. Ultrasound is good if there's something on the imaging, if there's something that you feel. It could be a malignancy, it could be a malignancy, it could be a simple cyst. Ultrasound is wonderful in demarcating cystic tissue from other tissue. And ultrasound can convert a question into a definitive benign answer. This is gold. MRI shines with dense breasts. Okay, another movie, would that be okay? So this is a breast MRI, and you can see abnormal asymmetric enhancement in what could be dense tissue. Well, there's no mass. That could be a very infiltrative malignancy, or it could just be asymmetric glandular tissue. We look at the enhancement curve to find out. And there's another movie too, and I can answer your question. Well, sir, I owe you. I'd like to say, I don't want to be a double what I'm paying you. I don't. Yes, sir. Oh, good, you're locked on.
Yeah.
Could you play that?
Absolutely.
This is, okay, that's another, here we have computer-assisted detection with the MRI too. That's the earlier slide. You can play that too, because I want to talk about implants because I want to answer your question. We have computer-assisted detection for the MRI too, and that's in the substance of the breast, and that's a malignancy. Breast implants, what I want to, they complicate your imaging because the natural history of implants is to involute, calcify, and to leak. It's a complicated social issue, and I'm only qualified to speak to the medical stuff. But they do, they do complicate your imaging, and there's scarring that can form around the implants. I don't like tattoos either. I've biopsied now 2 lymph nodes, where what happens is the tattoo ink, you guys probably not so much, but like the kids these days, my goodness. Okay. What happens is the tattoo ink gets sucked up by the lymph nodes. It looks like calcifications, and you think it's a malignancy. And then you do the biopsy of the lymph node, you get tattoo ink, and you're thinking, oh well, that's a biopsy. But so, I can't speak to the social aspects of tattoos or implants, but I can speak to the fact that it can complicate your imaging. And I want to answer your question as diplomatically as I humanly can. Does that answer your question-ish, at least? Okay, then how can I do better?
Well, they were just on the news again this morning.
Oh, do they cause cancer?
Yeah.
Okay, yeah, I can actually,
You have cancer and they put an implant in after you had this mastectomy.
uh-huh.
What's the?
Okay, okay, if you've had a mastectomy, then that's okay. If you've had a mastectomy, then there's no glandular tissue there anymore. And therefore, the implants can cause trouble, but usually not breast cancer type of trouble. The implants that might be associated with malignancy, you want to play that, sir? Because there's a fine picture. That is a volume acquisition MRI. So so if you have glandular tissue, chronic inflammation can put people at risk for malignancies. Does that make sense? If you have a chronically inflamed colon, you're at risk for colon cancer. If you have chronically inflamed lungs because you're smoking, you're at risk for lung cancer. If you have a chronically inflamed biliary tree or gallbladder, risk for cancer. If you have chronically inflamed breast because the implants and the scarring, maybe that's a risk for cancer too. So if you have glandular tissue plus implants, that's kind of the worst of both worlds. Okay, thank you, sir. I'm grateful. I think that might be it. It might not be too. No promises. If you guys like, I could talk for probably too long. So if you say, "Hey, Tim, we're done," just let me know, okay? And if you're getting bored, you can head out. I'm not fussy. But anyway, in conclusion, that's the stuff we talked about. In conclusion, high-risk patients, if you have a elevated genetic family history of malignancy, 2 first-degree relatives, family history of ovarian cancer, MRI on an annual basis could find disease that the other modalities won't. If you have an early family history of breast cancer, like if you have 2 first-degree relatives, you should start your mammographic screening 5 years before that first-degree relative had disease. Does that make sense? Cool. So another question that came up, you asked a question before about, hey, what to do should we do mammograms at age 80 or 90? Some people say do mammograms every other year. I'm opposed. And the reason why I'm opposed is because cancer grows, and if I miss it, then we upstage people. So these are highly speculative models. Nobody does a randomized clinical trial where they leave cancers in people. So this is speculative. This might not be right. But it's probably close to right. So average malignancies are detected at about 1 centimeter or so to clinical. In most mammograms, we find it a little bit early. That's me bragging, but it's also true. But if the lesion grows about 7 millimeters every year, and if it begins at 1 centimeter, if we do the mammography every year, we're going to upstage people. And if you upstage people, you kill them, and that's not what we're supposed to do. So here, if you look over time, here's 1975. Here's 2010. Here's big cancers. We're finding them less often. Here's small cancers. We're finding them more often. This is proof that over the past 25, 30 years, we have been increasingly detecting cancers earlier. And that means fewer people are dying from breast cancer. This is one of the reasons why. And here's a tumor growth model. I pulled that out of a journal. It's speculative, but cancer grows. If you get screened every other year, and if we miss it once, we may have done harm. So get screened every year. So we talked about the default modality. Our default modality is 3D imaging, especially useful with women who have dense breasts. For women younger than 45, mammography is still effective. The window of early detection is still there. here's our institution, here's the distribution of cancers that we had over a 5-year time frame. So you'll see people who are 85 to 90, they'll have cancers too. And with some frequency, some material frequency. So that's the frequency, that's the age frequency of the cancers that we found here. For male malignancies, because part of this, because males get chest wall cancers too. Most breast cancers, are found by imaging, but an important fraction of breast cancers are found by women's self-examination. Men, not all men are not all men are most men, but men are psychologically different. Men, some of them don't ever see the doctor, and some of them don't go anywhere near their own bodies if they can avoid it. But if there's a palpable abnormality, surgery is the most common entity, and we treat these rare malignancies, less than 1% of total breast cancers. We see maybe 1 or 2 male breast cancers a year. We see female breast cancers, oftentimes every day, certainly every week. And family history still applies. Physical examination, lump, and otherwise they're treated like, yes ma'am? Yeah, I just know what I see here locally. In terms of market share, we have about 60 to 70% of the breast imaging. So everything that I say you can multiply by like 1.3 for the whole Tri-Cities. We only, but about what'd I do? Okay, so we have, male breast cancers, we see maybe 1 or 2 a year. We image males with more frequency. We see 1 or 2 men a week. Usually they have what they call gynecomastia, which is a proliferation of retroareolar glandular tissue, or they have pseudogynecomastia. Some medications will cause either. But if you have a physical exam abnormality, it needs to be worked up, just like the folks of the female persuasion. And the clinical signs of a male breast cancer are very similar to the signs of female breast cancer. Another thing I want to talk about is mammography and demographics. If you look at this curve, folks of the African American persuasion have a lower incidence of malignancy than folks of Hispanic and Caucasian demographics, but their mortality is higher. If you look at the group, the incidence of disease is less, but more of them die from it. I mean, think about that. And why might that be? Yeah, access to care, access to clinical care, and they're diagnosed generally later. Yes, ma'am. I have a video about, this is about an African American woman who was diagnosed with a breast malignancy. She ended up being a save. So this is just a human story because every number has a human being attached to it. That's okay. I mean, just as long as you see our fellow human being's face. And what happens is, if access to care is compromised, the diagnosis is ultimately made, but it's ultimately made sometimes too late. One of my first patients, when I was an intern in Philadelphia, was a wonderful African American woman. She's about 40 years old, and she had a cancer eating out the side of her chest wall. And it was almost certainly too late, and she had a couple kids in tow, and you could see the future before it happens, and it was just a miserable, miserable thing. And you kind of wish it didn't happen, and the answer is early detection. So, that's another good thing about the Catholic Foundation. When I was dropping off my slide deck the other day, I saw in the Catholic Foundation there was some people talking to an underserved member of our fellow human beings, and they were getting that person set up with the medical care that they needed, and helping them with the cost. I don't know the details. They keep me far away from the money. But, I would just, if to the degree, I can move past it. To the degree that we can make these bad things less by making sure that everyone has a chance to participate in life-saving care. Thank you to the Catholic. Are there any Catholic Foundation people here? Well, maybe we'll have some information for them about the foundation later.
We have out on the table a pamphlet from the foundation.
Yeah, so if you guys want to take that, and if you want, you can leave your email with her, and if you want to copy the slide deck. I can't actually send it to you by email because it's bigger than what Gmail will allow, but I'll get it to you somehow, I promise. But anyway, my point was that if we can make life-saving care as widely available as possible, we'll have served our fellow human beings, and that's the goal. Yes, ma'am? Oh, you're just saying. So that's pretty much what I got. I don't know if I have too much more.